Joining us today. My name is Dr. Elijah Matolo from the UAP Insurance Health Business. We are very pleased today to have the team from Aga Khan University Hospital to take us through this webinar on cancer. And today we are joined by Professor Mansoor Saleh, who is the founding chair of the Department of Hematology and Oncology at the Aga Khan University Hospital, and is also the founding director of the Aga Khan University Hospital Nairobi Cancer Center. So we'll go straight into the presentation. So welcome, Professor.
Thank you for inviting me, and I hope that we will share some information about cancer. February was the cancer month, where we would talk about cancer in general. March is colon cancer month, and I would talk about a general picture of what is cancer, how we can prevent cancer, how we can detect it early, and maybe a little bit about treatment, but more importantly about how to prevent or to detect, which is the best way of ensuring cure. So you see the picture that you just saw. This is the Aga Khan University Hospital. We're 60 years old. On the right, you see the old hospital. On the center, you see the Heart and Cancer Center, which is what you see when you come to our institution. Next slide. So I want to just talk about what is the most common cause of death in the developed world, which is North America, etc. Heart disease is the most common cause of death in the developed world. Number one. Number two will be stroke. Number one is heart disease, number three is stroke, and number two is cancer. So you can see cancer is very common in the developed world. If you look at the developing world, which is where we are today, infectious diseases was top, but now it has been overpassed and overtaken by heart disease, cancer number two, and stroke. So we are starting to behave like the Western world because we are eating like the West, we have pollution like the West, stress like the West. So I want to go back to see, we need to go back to where we came from, which is agriculture, home cooking, etc. We'll talk about that. Next slide. So I want to talk about what is cancer. I want people to understand what is cancer, how we diagnose cancer, how we detect cancer early, and then tell you why it is important to detect cancer early, because it makes a difference between life and death if you detect cancer early. Next slide. So these are slides. This is data from 2016, so nearly about 5 years ago. This is the United States, but we would look very similar to this. Heart disease was most common, 24% in men. Cancer was 22% in men. If you look at women, heart disease was 22% on the right, and cancer was 21%. So you can see that in the developed world 5 years ago, heart disease followed cancer. If you look at Kenya today, infectious diseases would be number one, but very quickly thereafter would be heart disease, and number three would be cancer. So we know that we are really behaving very much like the developed world because infections are being controlled by antibiotics, HIV by antibiotics, COVID very soon by vaccination, but those concerns of the heart and cancer become predominant. Next slide. So the question is cancer preventable? Is there anything you can do to prevent cancer? The answer is yes. Your lifestyle is important. Next slide. Chewing tobacco. We don't do that very often here. The Indians chew this pan stuff, the Asians, which is why they get head and neck cancer. But our diet is important. High fat, low fiber is a prescription for cancer. So if you as a young child have a high fatty diet, are obese, have low fiber, and do not exercise, that predisposes you to cancer. And there are many experiments that do that in animals that say, yes, animals who do not exercise, get high fat, low fiber, have a higher predilection to cancer. So diet next is very important. The environment, not only what you eat, but what you breathe and all the other stuff, chemicals, preservatives, etc., sunlight. In Africa, Africans obviously have a black skin, so they're protected against the UV light. I, who's Asian, have a slightly tan skin. I'm more predisposed to UV light, and the Caucasians have a very light skin. So for them, sunlight really is predominant, one of the causative factor for skin cancer. To prevent cancer, though, we can vaccinate. If we would vaccinate every boy and girl who is the age of 10 up to 18 for the HPV vaccine, we would eradicate cervical cancer in Africa. Done. Cervical cancer is the second most common cancer in Africa. It is caused by a virus, the HPV virus, and you can vaccinate your child starting at the age of 10 to 18. And if we did that, we'd eradicate 98% of cervical cancer. Hepatitis B is also a killer in South Asia, not as common here, but we can vaccinate against hepatitis B and really eradicate liver cancer. So you can see that vaccination play a very important role in certain cancers, cervical cancer and liver cancer. Next slide. This slide shows you where diet and obesity plays a role. Breast cancer, women who are obese have a higher risk of breast cancer. Colon cancer on the right, again, obesity increases your predilection to colon cancer. And on the left, uterine cancer and ovarian cancer. So women who are obese clearly have a predisposition to breast and ovarian cancer, but also colorectal cancer. So you can see that if you want to reduce your obesity, a number of cancers could be reduced and is very, very critical. Next slide. So let me talk about cancer. What is cancer? How does it spread? On the top, you see the primary tumor. You know, cancer is cells that have a genetic alteration from normal, and they grow very quickly, much faster than normal cells. So growth is one of the factors which makes a cancer cell different from a normal cell. But the other one is invasion. You can see that there's a basement membrane. It's like a lining of the skin. Normal cells will not invade to the lining of the skin. So you get a pimple, it grows to the outside. It may press your skin and hurt you a little bit, but it would not invade the basement membrane. Cancer invades the basement membrane, and very quickly, by invading the basement membrane, it goes down into the blood vessel. You can see the blood vessels and the lymphatic vessels. So there are three things that make normal cells become cancer cells. Genetic alteration that increases growth, local invasion to the basement membrane, and three, spread into the bloodstream and to other parts of the body. We call that metastasis. What kills a cancer patient is metastatic disease. You want to avoid these cells that have invaded through the basement membrane to getting into the bloodstream and spreading elsewhere. Let me explain to you what metastases are. So here you are. If you look at normal breast cells on the top, it becomes malignant because of genetic manipulation. And then when the breast cancer cell spreads in the bloodstream, it can go to the lung, the liver, the bone, and that is called metastatic disease. You want to avoid getting to metastatic disease. You want to catch the cancer before it spreads into the bloodstream. Next slide.
Spread of tumors to distant locations is of great importance in cancer. About 90% of the deaths due to cancer involve tumors that have spread around the body. The movement of tumor cells to other parts of the body is known as metastasis. Metastasis is a complex process during which cancer cells break off of the original or primary tumor and move through the body to form tumors at new locations. From the point of view of a cancer cell, this is a dangerous and often unsuccessful process. A trip through the body is full of hazards that cause the death of most cells that begin the journey, even tough cancer cells. To begin the process, individual cells must break away from the tumor and invade nearby vessels. The cells crawl along the surface of other cells and the fibrous, stringy structure surrounding them and then force their way in. Shown here is the invasion of the blood supply. Once inside a blood vessel, the cancer cells may perish from a variety of causes. Some cells die simply because they are unable to survive floating around in the bloodstream. Others may become damaged and die when they squeeze through tight spaces or bump into the walls of the blood vessels. Still, other migrating cells may be recognized and destroyed by cells of the immune system. How and where the migrating cells stop is different for different cancer types. Once the tumor cells are no longer moving, they can begin the process of forming a new tumor by leaving the blood vessel and beginning to reproduce in the new location. This does not always occur, and cells that have made it this far may still die or fail to divide. If the new environment is suitable, the newly arrived cell will begin to grow and a new tumor will develop.
And this is what is called metastatic disease. So if you have a patient with breast cancer and the cells metastasize to the lung or the liver, and when the patient dies, they die of breast cancer. They do not die of lung cancer or liver cancer. They die of metastatic disease of the breast to the lung and the liver. So it's very important to understand the process of metastasis. And if you can stop the tumor before it spreads to the blood vessel, the chance of cure is very high. We'll talk about that. Next slide. So how do you diagnose cancer? A number of cancers might have symptoms, but a majority of cancers have no symptoms, no pain, no nothing. Sometimes women have swelling of the breast. It could be normal because of your periods, or it could be a tumor. The tumor could be benign or malignant. So you should not depend upon symptoms. Physical examination is helpful to draw attention, but it's also not very beneficial. The most beneficial test is early detection. We can do some blood tests, and they can detect some tumors early, like blood cancer, that can be detected early by a blood test, but it's not very common. In the future, we can detect tumor cells in your blood cells. That is called circulating tumor DNA. We can pick it up with the genetic material from your tumor. We can pick it up in your bloodstream, and there'll be very early diagnosis. We don't have that as yet. But the best way is early detection, biopsy, and that's why we have cancer screening tests. Next slide. So what are common cancer screening tests? Chest X-ray or a CAT scan for smokers, very important. We can pick up lung cancer when we do that. A PET scan, we'll talk about it, not a very important or good early diagnostic test, but very good test to detect if the tumor is spread. MRI helpful, but only for disease of the brain, not a good test for early detection, but clearly a good diagnostic test. Mammography, very, very important for women to detect early breast cancer. And then also we talk about ultrasound, and blood tests are good for diagnosis of spread, but not for early detection. Next slide. So let me talk about some of these tests. A chest X-ray. Everybody knows a chest X-ray. You sit in front of a machine, they spread the rays through your body, it goes out onto the film. The film looks like this. In the middle, you see your big heart and your blood vessel. On the right and the left, you see the lung, and you can see clear air, and you can see the ribs. If there was a lesion, a pneumonia or COVID, you would pick it up on an X-ray. But sometimes the findings are very subtle, so we do a CT scan. What is a CT scan? Next slide. So we put you through this little tunnel, this white donut. You're sleeping on this little bench. The bench will go through this tunnel so that the tunnel will slice your body in 5mm sections. So the X-ray is slicing your body from head to toe while you're going through this tunnel, and every slice shows up as an extra film. Next slide. So you can see on the right, multiple sections of your body. In the middle, I picked up a section near your umbilical cord, near your navel. On the left, you can see the big liver. At the bottom, you see the two kidneys. You see the spine in the middle of the kidneys. In the front, you see your stomach. In the middle, you can see the pancreas. So when we do a CAT scan on a patient with symptoms, we can identify all the organs and pick up lesions or tumors in the abdomen. Not a good early detection test, but once you have symptoms, we can do a CAT scan to find out. Next slide. So look at this. On the top right, you see a chest X-ray, and you see this white shadow, a big shadow, and you say, well, is it infection? Is it cancer? You also see a little shadow on the left-hand side in the middle there. So we do a CAT scan. Look at a CAT scan. Very quickly, you see this big mass on the top right. There is gray stuff, so that's like fluid, and there is less gray stuff, that you know that's solid. Is it infection? Is it abscess? Is it cancer? So to differentiate between a benign and a malignant tumor, we do a PET scan. We at AKU are the only ones who have a PET scan at the moment. So here you are. On the left-hand side of the screen, you see a mass on the top of the breast. On the CAT scan, you see the mass. You aren't sure, is it malignant, non-malignant? So let's do a PET scan. On the right, you see the PET scan. The PET scan shows that this mass is hot, red hot or yellow hot. The way it is we give you an injection of radioactive glucose. A tumor which is growing quickly will pick up radioactive glucose, and the radioactive glucose shows up as yellow or red. And that is the difference between a benign tumor and a malignant tumor. Next slide. So look at this PET scan. On the left side, you see a left PET scan of a patient with cancer. Everything that you see there, yellow or red, is cancer. The whole body is cancerous. Even in the legs, you see at the joints, there is cancer. Now, the brain is hot as well, not because the patient has cancer, but because you cannot stop thinking. When you think, your brain takes up radioactive glucose, so the brain is always hot. We cannot pick up brain cancer because your brain is always hot because you're always thinking. So we tell the patients, don't quarrel with your wife before you come to have a PET scan. You lie down, take it easy, take a chill pill. We put you in a dark room, and then we do the PET scan. So look at the left side, PET scan before treatment. On the right, PET scan 2 weeks after treatment. All the cancer is gone, except for the middle, you see the heart, which is where the blood is, which is why it's hot. And the brain is always hot. At the bottom, you see the bladder, which is hot because you pee out, you urinate your hot radioactive glucose. But nearly all of the cancer that was there 2 weeks ago is gone because we were to give the patient a very targeted therapy molecule that blocks and kills the cancer. Same thing on the right. On the left-hand side, this skeleton is full of metastases. All the bones are full of cancer. 2 weeks after a pill a day, all the cancer is gone. That is the power of targeted therapy of cancer. And when we know certain genes that are upregulated, we can block those genes with either a pill or IV medication. And that is the dramatic response we see. And you can see it on the PET scan. Next slide. This is an MRI. MRI is good to detect brain tumors or a stroke. It is quite different than a CAT scan. It does not use Xray. It just uses magnetic resonance. And in the lower right, you see the brain with this white lesion, which is the tumor. So we can very quickly pick up a tumor in a patient having a headache or blurred vision by doing an MRI, which is different than a CAT scan. Important in MRI is because it's magnetic, you could not have any metal in you. So if you have a heart valve, which is metallic, or you have a clip in your head, which is metallic, we cannot do an MRI. We have to have non-metallic clips to be able to do an MRI in a patient. Next slide. Mammography. This is mammogram, very important for a woman. You can see on the left-hand side, you have a side view of your breast. All this is breast tissue. On the right-hand side, you see a top-down view where we squeeze the breast. It's quite painful for women, but it is very important. The only way to get a good mammogram is to squeeze the tissue so we can get good penetration. You can see blood vessels, you can see breast tissue, and then you can see tumors. Next slide. So here you are, a mammogram, side view and top-down view, and there you see the cancer. It's very important to flatten the tissue so you can separate blood vessels, which you see many, from the tumor. Next slide. So you can see, for example, on the left-hand side, you have an older woman who has only fat, no breast tissue. It's easy to see the mammogram right through. Look at on the right, all the way right, you have a patient who's a young woman who's breastfeeding, dense breast tissue, very, very difficult to see through this mammogram. So that's why we have sometimes to do an MRI of the breast or the ultrasound. So your age makes a difference. If you're above 50, above 40, mammography is very good. If you are less than 40, we do mammography plus ultrasound. And this is a reason why a young woman who's lactating, breastfeeding on the two right-hand mammograms, very difficult to pick up a tumor. Next slide. So we do an ultrasound. Here you are. This ultrasound shows this fluid collection in the middle, dark, which is a cyst, But within the darkness, you see little tentacles which are gray. On the left, for example, at 9 o'clock. And 9 o'clock, there you see the tumor into, that is, no, innocent, into, even innocent cannot read a mammogram, but he's not a mammographer. But to the right of that X arrow, you can see this is to the right. Yes, you can see like a little finger. That is this tissue, which is like malignant. So within this cyst, which is fluid collected, there is this gray tissue. So we have to biopsy this lesion, which is why it's important to do an ultrasound linked to a mammogram. Next slide. So look at this breast on the right-hand side. You have the breast, you have the lymph nodes, and the tumor can come from the breast, spread to the lymph nodes, and from the lymph nodes, spread into the bloodstream. So look at it on the left-hand side. Stage 1 is the lesion is only in the breast. It's a small lesion, less than 2 centimeters. The cure rate is 88%. You want to pick up your breast cancer very early. Stage 2 is a tumor which is more than 2 centimeters. And the cure rate down is about 60 to 70%. Stage 3, the orange bar, is where the tumor has spread to the lymph nodes, those green lymph nodes in the axilla of this patient. When the tumor is spread to the axilla, it's called stage 3. And the cure rate of stage 3 now is about 40 to 50%. Stage 4 is the tumor has spread to the bloodstream and gone to the liver or the lung. Cure rate is 15%. So you can see that it is very important for a woman to pick up breast cancer early, stage 1 or stage 2, cure rate of nearly 75 to 90%. That can only be done by mammography or ultrasound. Even feeling your breast will not pick it up. It's healthy to feel your breast every month at the same time, but it is important to know that if you're above the age of 50, you need an annual mammogram. And I would start at the age of 40, one mammogram to be sure that things are fine. The next one 5 years later, 45, then 50, and annually thereafter, because you want to pick up your breast cancer if you are going to have it in stage 1, stage 2, not let it spread to the lymph node stage 3, and certainly not let it spread elsewhere. Next slide. Next slide. So you can, okay. So you can see stage 1 is a small tumor, less than 2 centimeters. Stage 2 is more than 2 centimeters. Stage 3 is the lymph nodes, and that's how disease progresses. Next slide. So let's talk about colon cancer. You know, the colon is here about 8 feet, and the small intestine, which is the small bowel, is nearly 21 feet. Most of the cancers reside in what we call the sigmoid colon, the last 12 or 18 inches in this area. Very few cancers happen on the right-hand side. Most cancers are on the left-hand side. So the best way to detect colon cancer early is a blood test, a stool test to see if you've got blood in the stool. We do that, we call it a fecal occult blood test. And starting March, which is coming up next month, it is colon cancer month, we'll be working with a number of corporations. Hopefully we can work with your corporation as well. We'll be offering education like I'm doing now, and a stool blood test. If you have a stool blood test, the risk of having colon cancer is high because bleeding from the tumor can get to your stool, and we can test your stool for blood. Now, you can also have blood in the stool if you ate meat, or if you have a polyp or a hemorrhoid. So a stool blood test is not very sensitive. The best way to detect colon cancer is colonoscopy. We go with the light all the way to the colon, all the way down to the left-hand side where you have the little appendix. It's about 10 minutes. It's all done very quickly. It's the best way to detect colon cancer early, and that's what we do when we do early detection of colon cancer. But we can still offer you a stool blood test. If the blood test is positive, then you have to have the colonoscopy. Next slide. So look at this. Stage 0 is a very small tumor. You can see it, a pink. It has not spread through the lining of the colon. The colon is like a pipe. It's got many layers. You've got the pink layer, the white layer, the muscle layer. So stage 0, it has even not infiltrated into the pink layer. The cure rate is 100%. If you pick it up by colonoscopy, the surgeon can remove it, you're cured, you're done. Stage 1 is the tumor has now gone to the pink layer, nearly into the fat layer of the tissue. Cure rate is still 100%. Stage 2 is it's gone through the fat layer into the muscle layer. You can see that it's gone to the muscle layer, and the cure rate now is 80%. Still a very good chance of cure. If you don't pay attention, now you've got blood in your stool, you've got pain. Stage 3, it has gone through the lining to the fat, through the muscle, into the lymph node. You see the green lymph node is positive. And once it spreads to the lymph node, it becomes stage 3. The cure rate with surgery is down to 60%. So you went from a cure rate of 100% stage 0, stage 1, down to 60% because you neglected the fact that you had blood in your stool, you thought it was hemorrhoid, you had pain, you had some constipation, you thought it was bad food, and you were not paying attention. So we're going to offer fecal occult blood tests next month for corporations, for their staff to participate, and then those who have a positive blood stool test to have a colonoscopy. You want to pick up your cancer, stage 0, 1, or 2. Worst scenario, stage 3, cure rate 60% with surgery, but you will need chemotherapy. And look at stage 4. It has gone through the entire lining into the lymph node and out to other organs, and the cure rate of stage 4 is 15%. You do not want to wait that long. And the trouble I have that I see in Kenya and in Africa as I see it here since the past year, most women come to me with their cancer having spread stage 3, stage 4. Very difficult to cure. Most men and women, and we see young patients in Africa having colon cancer at the age of 40. In the North American setting, it happens in 50s and 60s. In fact, the most common age for colon cancer is 65 above. We see at least 20% of our patients in Africa who are 40 and less who get colon cancer because we do not know why. But they've neglected the fact that they had blood in the stool, there was hemorrhoids, constipation, etc., and then neglecting, and then you come to us with stage 3, stage 4, very difficult to cure. So very, very important to participate in the colon cancer screening that we'll be doing next month. Next slide. So we established a clinical research unit here at AKU in the past 1 year. Innocent is the navigator. He oversees many of the operational activities of the cancer center. On the right, you see the cancer center, our architectural diagram. And the reason why we did this is when I came here, there was this article, 30th of January 2020 in the Daily Nation. It says, cancer research from the West will not work in Africans. Well, it's true. Our genetic makeup is different. We metabolize drugs differently. Certain drugs may not work for us, and our cancers might have a different tumor genetics. So we should do research on our patients in Kenya on our tumors. So the genesis of the cancer research unit, the clinical research unit at AKU, is to do research in Africa on Africans using our tumors, using drugs that were developed in the West to see if they work for us in Africa. So that is the important part why we do research here. We are one of the first clinical research units in sub-Saharan Africa dedicated to this particular cause. And you can see Dr. Rashid Aman, who is Chief Administrative Secretary of the Ministry of Health, opening the clinical research unit with Dina Toli on the right-hand side and a number of our dignitaries. And you can see us all with a mask because this was at COVID, which was just about October. But the CRU is dedicated to cancer research. Next slide. So I'm going to let you focus on this a little bit because those are my last 2 slides. We took tumors from Kenya, took them to my institution in Alabama, and compared the genes of breast cancer tissue from aggressive breast cancer from Kenyan women on the middle row, Innocent, and compared this to the same genes of African-American women in Alabama, the right row, and compared these to the same kind of tumor, aggressive tumors in Caucasian women on the left row. So each of these dots is a gene. And you can see that in the Kenyan women in the left, in the right, you've got hot spots, red spots that are not present on the right, African-American, nor are they present on the left, Caucasian. So we do have a number of genes that are different in our aggressive tumors compared to Caucasians and African Americans, which is why we in the clinical research unit want to do research to identify these genes. What are these genes? What are their cause? Can we block them as a way to treat a patient, or can we detect them early as a sign of cancer? Next slide. Same thing, look at this. The middle is Kenya, left is Caucasian women in Alabama, right is African American. You can see both the African American and the Caucasian have red spots. We don't have those red spots in the Kenyan women. So certain genes that are downregulated in African American and Caucasian are not downregulated in Kenyan women, which is why the ethos, the objective of the clinical research unit is to study cancer genetics in Africa to determine are we different than Caucasians or African Americans, and what can we do about this for early detection and treatment. Next slide. I wanted to talk about prostate cancer because prostate cancer is very common in Africa. We see prostate cancer in North America in men ages 50 and above. In Africa, we see it more commonly. There's a PSA test we do in North America. We don't advocate it because PSA can be upregulated or positive when you have an infection or when you have obstruction. But we are proposing also during the month of February to offer PSAs to men who are younger, who might have trouble passing water, who might have a family history of prostate cancer. You should have your PSA checked because prostate cancer is quite common in younger males in Africa. So I talked about early detection, the risk of diet in predisposing you to cancer. And I talked about how to detect cancer early. In breast cancer, it's mammography. Colon cancer is fecal occult blood test and colonoscopy. In prostate cancer is PSA. So I think I have about 20 minutes we can answer questions, but this is what we're about here at AKU, both in the Hematology Oncology department as well as the research unit in the CRU. So thank you.
Thanks a lot, Prof. That was quite so some question from our attendees for the session today, and I think I'll just begin with the first one. So we have a question here. I have some fatty deposits, in bracket lipomas, on my hand tissue, which have been in place since I was young. However, of late they have increased and moved to other parts of the bodies, that is the thigh. Is this a cause for me to be concerned and get a cancer test? And if yes, which test? Innocent, you can unmute so that we can hear Prof.
Yeah, what I want to say is I didn't want to indulge in single questions of individuals. But for this person, if these are literally lipoma, there's a condition called lipomatosis, where you can have many lipomas throughout the body. They're all benign. However, some lipomas can become sarcomas, which are cancer. So I would go and see a doctor, not necessarily a cancer doctor, I would see a dermatologist, let them evaluate, even biopsy, because this could be just benign lipomas and they are a nuisance, but they could be liposarcomas, which are hereditary, and that's a very different cancer. So, but I wanted to avoid to having individual question answered here because it can become very risky. Yeah, but I would see a doctor, not necessarily an oncologist, and have a biopsy done by a dermatologist who then sends a tissue to an expert. They can send it to here, AKU Pathology, so we can review it.
Thanks a lot. There's a question here about the risk of breast cancer in males.
Good question. 10% of breast cancer happen in males. It's probably the size of our breast tissue. It may be about 5% of, or even 3% of a female breast tissue. So our risk is much lower, 1 in 10. However, as we age, men also produce female hormones, estrogen. which is why as you age, your breast tissue becomes bigger. So we have risk factors for men for breast cancer over time. And just by feeling, because you don't have much fat tissue, you can pick it up very early. We do not advocate mammography for men, but men can do self-examination. And 1 in 10 cancers of the breast can occur in men. And the treatment is similar to breast cancer of the women.
Thank you. Another question here. Are frequent headaches a sign of head tumor?
Very difficult. You know, headache could be stress, could be allergies, could be sinuses, could be bad glasses. Very, very difficult. Headache, as I tell my doctors to say, if you have a patient with headache, you have to give me a differential diagnosis. What could it be? Sinus infection, bad quarrel with your wife, bad eyeglasses. Cancer would be number 55 on the list. So, but still you have to go and see the doctor and be sure that change of headache pattern could be migraine, change of headache pattern with other symptoms, loss of vision. Wow, that could be a stroke, etc. So very important to have a doctor give you some information about that.
Okay, thank you. So a question here, is there a difference between the term tumor and cancer? And are you able to differentiate between malignant and benign?
Right, so tumor is a growth. Any growth, a pimple is a tumor as well. The other person talked about fat tissue, it's a tumor too. So any abnormal growth is a tumor. So if you look at your skin as you age, you'll have pimples on the face, everywhere else. A woman on her breast tissue will find little lumps and bumps. Those are tumors. A benign tumor is one that does not grow very fast, does not invade, does not spread. A malignant tumor has those three characteristics: grows very fast, will invade, and will spread. The only way to know whether it's benign or malignant is to take a biopsy and look at it under the microscope. So that's why you do a mammogram, you see a lesion, ultrasound, we do a biopsy. You do a colonoscopy, you see a polyp, we do a biopsy. So biopsy is the only way to differentiate between benign and malignant. Most tumors, most growths are benign, but it is difficult to say which is which.
Okay, thank you. Another question here, someone who has a stage 3 uterus cancer and almost done with radiotherapy, but cannot start chemotherapy because of high levels of creatinine. So how can she reduce the levels of creatinine so that she starts chemo?
Well, creatinine is when your muscle breaks down, you make creatinine. And creatinine is excreted in the kidneys, into your bladder, into your urine. If your kidneys are not functioning well, the creatinine from your muscles stays in your bloodstream. So a high creatinine is a sign of kidney dysfunction. So you have to see the oncologist and a kidney specialist. There may be a blockage of the kidney, so we have to put a stent. There may be severe kidney dysfunction, you may need dialysis, or you might have high blood pressure or diabetes. If you fix that, your kidney function will improve. So the high creatinine is a cause, is a symptom of some other cause. We have to fix that other cause so that we can then give you the right chemotherapy. Because if your creatinine is not being peed out in the urine, then our chemotherapy also will not be peed out in the urine, and it causes significant toxicity. Or we have to choose another drug that is not excreted by the kidney. So very important to see the oncologist, and between the oncologist and the kidney specialist, nephrologist, they will come up with a fix.
Thanks, Prof. So 2 questions here about MRIs. So the first one, does an MRI show cancer stage? And number 2 is, why is one unable to do an MRI when they have a plate in the body, following a plate fix following an accident?
Right. So, MRI is magnetic resonance. We have huge magnets that really create a high vibration, and they vibrate the water molecules in your tissue. When the water molecules in your tissue vibrate, they give the images that I showed you. You can imagine if you got a plate and I give you a big magnet and it vibrates, you will probably blow up. So you cannot, even a small metal will cause havoc. So you cannot have an MRI, you have to have a CT scan. Even the plate will distort the CT scan, but at least it will not cause any toxicity. So anybody with any metallic object cannot have the MRI. An MRI does not tell you the stage of the cancer. It tells you whether you've got a tumor, whether it looks benign or malignant. The tissue biopsy will tell you what kind of tumor it is, and then staging, CT scan, etc., PET scan can tell you what the stage is.
Thank you. So someone with frequent painful face lumps with pus, is that an issue?
Frequent face lumps that have pus is usually acne. Acne is very different than cancer. It is a source of infection or a source of pain, source of many pimples and swelling. Dermatologist is the best person to go and see. Could be hormonal, could be infection, could be just too much sweat tissue because of sweat glands. So there are a number of treatments for that, but clearly not linked to cancer in general.
Thank you. So there's a question here. Can I just walk into a hospital and ask to be tested for all possible cancers? Is that practical? And maybe while at it, maybe you can comment on the use of tumor markers. I think you'll find a lot of people advocating for testing for usual tumor markers.
Yes. So good question. Yes, you can walk in and ask for cancer. We'll be happy to take your money, but I think you'll be wasted money. I would say that you go to the NIH site for Kenya or the NCI site for US or the American Cancer Society or CASHO. We have website that says, what cancers should you be screened for at what age? Women above 50, breast cancer, men and women above 50, colon cancer, men above 50, prostate cancer, etc. And I would do it in a targeted fashion. So you go to your regular medical doctor, say, this is my age, I have no symptoms, I want to have early detection of cancer. If you're very young, we would not do that because you're very young. But you have a family history, we'll say, okay, what's the family history? Breast cancer? Maybe we should do a mammogram early for you. Or you have a family history of prostate cancer. Maybe we should do an examination of the prostate and a PSA. So I think early detection should be targeted by family history, your age, and risk factors. So I wouldn't just walk in there, it'll be just wasted money, and then you would not know what to do. Talk about cancer markers. Tumor markers are not specific for the tumor. So for example, when breast cancer spreads, there's a marker called CA15-3. It is negative when you have an early tumor, which is stage 1, 2, or 3. So your marker is negative. Colon cancer, the marker CEA may go up only after the cancer has spread. So if you wait for the marker to go up, it's too late. Ovarian cancer, the marker goes up. By the time the marker goes up, the tumor in the ovary is spread to the abdomen. So we do not have tumor markers for early detection. We use them to follow the progression of disease. Yeah. The only tumor marker that we believe is helpful is PSA, prostate-specific antigen. But even PSA, if you have an enlarged prostate, PSA may be high. If you have prostatitis infection, urinary tract infection, PSA may be high. If you had intimate activity in the last 24, 48 hours, PSA will be high. So I would not just walk in there and say, by the way, do my PSA. It's very important to see your local medical doctor, and then depending upon your age, your symptom, your family history, to get targeted evaluation for early detection. This is a cancer month, February. Next month is colon cancer month. So I would follow that. And each of those months, we would be giving vouchers for early detection tests at a much reduced rate. And then you can participate. But the best thing is to be guided by your doctor.
Thanks a lot. A question here, what is the cause of cancer in kids?
The most common cause of death in young children, if you survive infection at the time of birth, is accidents, and the next one is cancer. We do not know the cause of death, the cause of cancer in children. The first one is clearly there are genetic mutations that happen. Sometimes a mother may be exposed to radiation, may take certain hormones, for example, and they may predispose the fetus to certain cancers. There are certain hereditary conditions that we know are spread from mother, father to child, and some of them are cancers. So there are many causes. Most of the time it is idiopathic, cause unknown, but it is caused by hereditary mutation in the young infant during the time of embryonal development. So to detect cancer in the child, a blood test is very important. Symptoms are very important. And then we do a family tree, because a family tree will determine, is this hereditary, not hereditary? Should we test for genes? Because if you have other children, they may be also predisposed to the same cancer.
Thank you. So I think maybe there a point would be that people should share, their medical history. There's a person in the family with a history of cancer to take the immediate relatives, just so that everyone is aware, especially the children. So a question here. Someone says when people start manifesting weight loss after they are diagnosed with cancer, a month or so later, they don't take long before they pass away. In such cases, you realize they are probably at stage 4 cancer. Does it mean that there's no pain that one can realize if he had cancer? And how long does it take for cancer to go from stage 0 to stage 4?
So if you look at colon cancer, we have very good data. For colon cancer to go from stage 0, like a pimple in the colon, to become metastatic takes about, in fact, from stage 0 to stage 3 takes about 10 years, which is why we say colonoscopy once every 10 years. If you do a colonoscopy on me today and there's no polyp, then the risk of having colon cancer is very low for the next 10 years. If you have a polyp, which is less than stage 0, then you have to come back and do a colonoscopy in 5 years. So we know very well in colon cancer, from the time of an abnormal polypoid lesion to becoming cancer is nearly 10 years. Stage 0 to stage 4 depends upon the biology of your tumor. Now, in the patient that you talked about, weight loss has many causes: stress, not eating, overworking, COVID, etc., etc. But if cancer has spread, the cancer takes up all your energy, all your nutrition, your glucose, your protein. So you're losing weight as the cancer is growing. And it's like walking to the edge of the cliff. You can be stable every day, and the last step is your last. The last step is really your last step. But not all cancers are like that. Most cancers, by the time they get to stage 3, you have symptoms. Stage 4, you have symptoms, and it is unpredictable because some cancers are very rapidly progressing, and you can have death very quickly without treatment. Some cancers, even with stage 4. Look at the cyclist with testicular cancer. What's the name of the cyclist? Lance Armstrong. Lance Armstrong had testicular cancer. Stage 4, disease in the brain and the liver. He's kicking alive and well and cured. That stage 4 cancer can be treated very quickly, very easily with chemotherapy and surgery. But stage 4 colon cancer, very difficult to cure like Lance Armstrong. So each tumor is quite different.
What is the ratio of cancers in men and women, and what is the predominant cancer in Kenya today for men and women?
In fact, the ratio of cancer in men and women is nearly equal. If you look at it, maybe a little bit more men have cancer than women because of age, because men live longer than women, but it's 50-50. Obviously, breast cancer is more common. The most common cancer now today in Kenya is breast cancer. Used to be cervical cancer, it's breast cancer. Then followed by cervical cancer, and then followed by colon cancer. So you know the top 3 are cervical, breast, colon. In the men, it is prostate, colon, and then something else. So I think, but the ratio is 1-to-1 nearly.
Okay, so how regular should one carry out colonoscopy or endoscopy?
So as I told you, from a polyp to becoming a malignant tumor takes 10 years. So colonoscopy is once every 10 years. The stool blood test we do once every year, just to be sure you do not have any blood in the stool, because if you have blood in the stool, that may be the beginning of a polyp. So you do blood in the stool, positive, you get a history and physical, and then you do a colonoscopy. If it's negative, then once every 10 years. Yeah. And all those guidelines are available. If you go to the K-Show website and say cancer screening guidelines, they're very much available. And what we can do is we can have Innocent send you the website where in the diagram I showed you, it'll give you a global scan for Kenya. You can look at the data in Kenya for different cancers. Makes it very much informative, and then tells you in Kenya what are the guidelines for early detection.
I have someone. So, what are the early signs or symptoms of colon cancer? Because the mom was diagnosed with stage 4, yet she had no pain at all.
You know, I think if we ask properly, often we have pain. We say, no, it's just constipation. Well, maybe I ate Chinese food today, that's why I'm constipated. Or maybe I ate too many beans, I've got too much gas. Then you have constipation, say, well, maybe it was the food. Most people will have symptoms. Often we deny the symptoms, try to explain them with something else. It is usually unlikely to get stage 4 colon cancer without ever having its symptoms. Now it's possible. I had a patient just recently who was fine. 3 months ago, it's some constipation, some gas, came to the hospital and everything was okay. And today he's got stage 4 colon cancer. Happens. But if you pay attention to your body, listen to what it's telling you, you will identify a pattern. If you are always having regular bowel movements, now you get constipation, don't say it was a Chinese food or too much XYZ. If you all of a sudden have too much gas, don't say I ate too much beans from my farm. Think about it. If it continues, it may be a symptom of colon cancer. So I want to be very clear that we should pay attention to our body and listen to it and find out that we might have symptoms. Whether it's uncommon, there are stage 4 where things happen and you didn't know at all, and it's like wildfire. But I don't think that's the case in most of the people.
Okay, thank you. My patient, someone here says, my mom died of cervical cancer. Is there a chance that the children will suffer the same?
The answer is no. Cervical cancer, most of the time, is not hereditary. Remember, cervical cancer, most of the time, is infectious. It's caused by the HPV virus. What we found is, in some cases, when babies, let's say we have a woman with cervical cancer active in the cervix, and the baby is born, she's exposed to those cells. Even then, it is very, very unlikely that you get infected even at birth during the passage of the child through the cervix and the uterus. There's some cases described, but in general, cervical cancer is not hereditary. Just because your mom had it does not mean you have it, you will have it. It is caused by an infection. Infection spread between men and women. So the pap smear that looks at this lining of your cervix and tests for HPV, very, very important. Yeah.
What are the common risk factors for cancer in men?
As I said, in men, obesity is a risk factor. High fat, low fiber is a risk factor. How much it contributes, we do not know, because not every obese person will get cancer. Many cancers happen in young people who are very thin and healthy. So we don't know the quantitative contribution of obesity in diet. On the other hand, heredity, family history, very, very important. Yeah, if you have families of cancer, you are at a higher risk of having cancer. So I think for men, we know that obesity will predispose you to colon cancer and to prostate cancer. If you have prostatitis and large prostate, the risk of prostate cancer is slightly higher, not because a big prostate has more cancer, but because testosterone is not a cause, but will, in a way, predispose you to prostate cancer because it is the growth factor for your prostate cells. So men who have low testosterone are less likely to get prostate cancer per se. But all of that cannot be equated easily. So the best suggestion is when you're 50, you go to have your prostate exam and get a PSA. If you have family history, you go earlier.
A question here. I feel I have a growth on my right hand just above the scalp. What would it be? Is it cancer?
Very difficult to say. Most of the time it's not cancer. It could be a fat tissue, could be a ganglioma, which is a benign tumor. If it grows, if you pay attention to it, if it grows and hurts, you have to really pay attention to have somebody look at it and biopsy it or get an X-ray. Because clearly at that stage, if it's malignant, it will invade into the bone and the bone will show changes. Very important to see a doctor for that.
And a question here, someone has hemorrhoids after passing stool. There is blood on the skin and the tissue, but not in the stool. Is that a cause for concern?
Nobody can know with the naked eye if there's blood in the stool. Nobody. That's why we do the stool blood test. We take a very small little sample of the tissue paper with your specimen. We put a developer and we can see if there's blood. So when you see blood, it could be hemorrhoids or it could be a tumor very much in the lower part of your colon so that there is blood at the end. But like this hemorrhoid, it could be fissure, which is a tear in the anal ring. But it is important that you cannot just say it's just hemorrhoid and realize that you're losing weight, changing bowel habits, etc. If you're above 50 and you have hemorrhoids and you have positive blood in your stool, I would go and be checked just to be sure, because hemorrhoids can occur even in patients with colon cancer. You do not want to lose your life because the culprit was hemorrhoids, but actually you had colon cancer. Yeah.
Okay. What are the chances of a wart in the scalp that are not private and does not go away despite the treatment? What's the risk of cancer?
Well, very difficult to say. You know, warts are benign tumors caused by a viral infection. They've not become malignant. If they've been there for a long, long time, they're more just a nuisance, cosmetic. But as I always say, important to see a doctor because we cannot self-diagnose ourselves. And yes, sometimes it may be expensive. Get a biopsy done, and you might have to pay some money. Save it, do it, and then you are scot-free. Because on the other hand, if it's a lesion which is unsightly, that's not grown over 5 years, most likely it's a benign lesion.
Someone has a persistent cough and various tests was told that it was an allergy. The question is there a risk of lung cancer with such consistent cough?
I didn't get the question.
Sorry about that, I'll repeat. So someone says, my spouse has a consistent cough, which after various tests, it was an allergy, which started about a year ago. The question is there a risk of lung cancer with consistent cough?
Patient with persistent cough, living in Kenya, depending on what they do, can have allergies, can have infection. If you've got a persistent cough for 1 year, have seen the allergies, seen the doctor, you still have a cough, you have to have a CT scan. It's just a requirement. A CT scan is required for everybody who has gone through entire evaluation for allergy, infection, etc., and still having a persistent cough. I would have a CAT scan of the chest.
And the question here is colon cancer hereditary?
Yes. Well, 90% of colon cancer are not hereditary. You did not get the gene from your father or your mother. 10% are hereditary, and we can do a family tree. And in fact, if you come to us and you have cancer, we will do a genetic test that tells us whether this is hereditary or not. Because for you, it might be too late, but at least for your siblings and for your children, it's going to be very important. But 90% of colon cancer is not hereditary. In fact, 90% of cancers are not hereditary, but 10% of cancers are hereditary. Just like breast cancer is hereditary, 10%, in some cases even nearly 20%. There are certain types of aggressive breast cancer, which we call triple negative breast cancer, where 20% may be hereditary because of the BRCA gene. So there is no one answer that fits all. It's very important to know that 10% of most cancers are hereditary, 90% are not hereditary. Hereditary meaning it was passed on, the gene was passed on from the parents to you. 90% of cancers are caused by genes. 100% of cancer are caused by genes. Most of these genes are not in your sperm or your ovary. That's why they're not spread to your children. There may be genes in your tumor, which occurred in your normal skin. So for example, I'm a certain age, I've got normal colon, and a cell in my colon gets a mutation, becomes a tumor. That is a mutation that happened not because I got a bad gene from my father or my mother. That gene became bad in my body. That I will not pass on to my children. Yeah. So that is the difference between hereditary versus what we call somatic. Somatic mutation is a mutation that happens in your body as you grow and age. The genetic mutation, the hereditary mutation, is what is happening in the sperm, and the egg is passed on to you and is in your body and can become malignant.
Okay, thank you. Another question, my spouse has frequent urge to pee, and when he goes, just a little urine comes out. This has been on for some time, close to 2 years.
It doesn't sound like cancer, probably infection or some other conditions of the bladder. You can have a bladder neck, which is either not giving out enough urine, or there's too much being collected. There are inflammatory conditions. Doesn't sound like cancer if it's gone on for 2 years, but certainly if you have to see a urologist, then one may have to look at the urine itself or go into the bladder itself with an endoscope to see what's causing this. There could be irritation. There are some tumors, which are tumors of the bladder wall, that can cause exactly the same symptoms. But there are tests that the urologist can do to identify what could be wrong.
Question here. So, is there a stomach cancer, or is it just a colon cancer only?
No, every organ in the body will develop cancer, which is what keeps us busy. From the nose, you can get nose cancer, the throat cancer from smoking, chewing tobacco, esophageal cancer, very common. In fact, before colon cancer, esophageal cancer in Africa, in Kenya, very common. I'm not sure why. Maybe it's our diet. But clearly in Somalia, esophageal cancer very high because they chew cut and they swallow this stuff. It causes irritation of the colon, of the esophagus. So stomach cancer is the next one, less common than colon cancer. But every organ can develop a cancer.
Dr. Matola, you're on mute.
Yeah, a question here. Can eyesight be recovered with surgery to remove a pilocytic astrocytoma? And secondly, can it recur?
Well, the eyesight, the nerves of the eye go behind, they meet, and then go to the brain. Depending upon where your tumor is, it may be recoverable, but if we injured your optic nerve because your pilocytic astrocytoma was involving the optic nerve, then the eyesight may never come back. So it depends upon where the lesion was, the involvement of the optic nerve, and what was done at surgery.
Okay, thank you. And as we come to a close, the final question here, which I think is quite important from Kefa, what can be done to create awareness among Kenyans so that cancer is caught early and thereby preventing unnecessary deaths?
No, it's a very good question. Which is why I came to Kenya. I could have lived a happy life in America, and I think in Kenya, we are, but it's not Kenya specific. The same thing happens in America as well. We are not aware. Ignorance leads to lack of information. Lack of information allows misinformation and disinformation. And as a result, we do not prevent or detect cancer early. These kinds of programs to your constituency are very, very important. But my problem is that when we hear this, it is now 1 o'clock. We'll go for lunch. By tomorrow, we'll have forgotten. Those who are obese would say, I'm going to walk in Karura every weekend, come the weekend and say, well, let me have another, what is it that you have for lunch in all the time? Let me have another big McDonald's or something. Yeah. So I remember when I was a child, my father would give me a shilling, I would go and watch a Tarzan movie. And for the weekend, I felt like Tarzan. I could jump the trees, talk to the animals. Come Monday, I was at school, I forgot about Tarzan. Same thing happens. The next day, we'll be talking about cancer with your people, et cetera, but then the day after, we forget. So March is Colon Cancer Month. The program I've talked to you about colon cancer, we'll be giving out vouchers for stool blood tests. You should do that. You should see your gynecologist for a pap smear. If you're the right age, 50, you should go for a mammography. Just for Valentine's Day, we gave away vouchers for 250, how much? 2,500 shillings for a mammogram. Very cheap. You go for dinner and you give out $25 for dinner, which may not even have been good. Well, give your darling wife or girlfriend a voucher for a mammogram on Valentine's Day. When it's past, we can still do it and say, I'm sorry, I gave you a rose, but today I'm giving you a mammogram voucher. You will save her life. So what should we do in Kenya? We should become aware, we should become knowledgeable, and take away the ignorance, because of ignorance, we get disinformation, and then as a result, we do not do what is needful. But these kinds of things that, how many people are attending at the moment, can you tell me?
We are at 188.
188. And how many members do you have in UAP?
There are more than 200,000.
Okay, look at that. All right. Let's go to 200. 200,000, and so it's 0.1%. I would hope that at least 10% would listen to this, and at least half of those would pay attention and go. I know it costs money, but you can find ways to get it cheaper. There are times where every major hospital, including AKUH, provides subsidized early detection. I think it saves lives. And I blame the husbands when a woman does not come for a mammogram. And I blame the wife when she does not send her husband for a prostate cancer testing, even though he's been complaining about symptoms. So it is a family affair. So I would take that as my last recommendation.
Okay, thanks a lot, Prof. I think maybe, I don't know if those are your closing remarks or if there's anything else you'd just want to speak. The time has we've gone over the time that we allocated.
So I thank you for inviting me. I thank you for listening. I hope it was impactful. But as I say, talk is cheap. Only when you implement it for yourself is knowledge actionable. And it's only actionable knowledge that makes a difference between life and death.
Thanks a lot, Prof. So our dear attendees, I think we've come to the end of this session. We're very pleased today to have a very enlightening and I believe session, and I believe all of us now know much more about cancer. I think the question about taking action based on the knowledge that we've just received, I think that's what will really make a difference. And I know we have such kind of coverage within the medical covers that we provide. So then it's a question of making time available to get screened for cancer and also all the other common chronic conditions, so that we can continue living a healthy life. Thanks a lot. This is Dr. Elijah Matolo from UFP. Want to thank all the viewers and who managed to join this session. And we also thank the AKUH University Hospital team a lot for continuing to support us in such sessions. And thank you, Prof.
I would say that, in Swahili, people say, mimi sikujua. Well, today you cannot use that excuse, all right? All right, thank you.
Okay, thank you. We've come to the end of the session. Have a great afternoon.